motor neurone disease has been known to be a fairly distressing illness, and I've heard many fear that choking to death might be the way of dying. Can you comment on that?
Certainly. Thanks, Tracy. My experience is that in looking after patients for over the last 2 decades with motor neurone disease, that choking is not a way that our patients die. The majority of our patients die peacefully, sometimes with medication support, other times without medication support. The choking is a myth that people fear, or drowning are myths, and that's not been my experience. One of the things that I've seen with motor neurone disease over the years is that as the disease progresses, patients die often very suddenly without any warning and very peacefully. What's your experience when people are on 24 hours of non-invasive ventilation?
Yeah, no, I agree, Peter. I think from a non-invasive ventilatory point of view, there is this worry, as you mentioned, about being dependent on ventilator and how's the death process going to be. So with the breathing side of things, with the ventilatory support mechanisms, there is certainly we can adjust them appropriately. That at some point, if the patient decides that they don't want to continue and withdraw the ventilation, then that is not done abruptly, but we do it in a standardized way so that the ventilatory parameters are gradually down titrated, and that results in permissive hypercapnia, so carbon dioxide gradually rises up and the patient really sleeps, and then eventually that's the way they die. The other thing is about as you mentioned, the choking. I think appropriate head position and things during the day is definitely helpful in preventing. Sometimes the choking could be due to the tubes getting kinked, but again, certainly in my experience, there's no one who has actually had choked to death. So I agree. I think it's the death is in general it's peaceful death, and we provide support mechanisms for that.
And I guess if my experience in practice, if someone wishes to withdraw from ventilation after discussion with the patient, their family, their caregivers, I think that's a role that palliative sedation would be useful, and I do that in someone's home if that's their preferred place, or would bring them into the hospice to gradually provide sedation with a combination of midazolam or other agents, so they are sleepy when they're withdrawn from their breathing machine, and so they're asleep, using sedation preemptively so there's no distress experienced.
Yeah, I agree. It's my experience as well.
Yeah. I like the role of just-in-case medications, probably not used as enough, but we do, when we know someone is approaching their final weeks and days in any of our palliative care patients, but particularly with motor neurone disease, is to have a range of medications that may be required. And that would include midazolam, which unfortunately is not on the PBS, but it's not too expensive. That would include clonazepam in its various forms, be they drops or an injection. Morphine, again for breathlessness or for pain. Mm-hmm. And I also would have some buscopan or something similar for secretion control. Most of our patients don't have a need for much in the way of medication, but just having those at home, so if it is Saturday night that something changes, we've got them there and we can utilise them.
Yeah, I agree. I think it's a good idea because things tend to go wrong at odd hours, so it's good to have that packed there.
The other resource that we utilise a lot is the extended care paramedic service. And they liaise with us after hours, and we provide support for advanced medication use to enable someone to stay at home if that's what their preferred care place is.
The only other thing I'll probably comment on is, I think I forgot to mention, is about oxygen supplementation. Generally with motor neuron disease or any neuromuscular disorders, we don't recommend oxygen supplementation alone as a mode of relieving shortness of breath, mainly because the reason for breathlessness is not low oxygen, is usually muscle problem. So the non-invasive ventilation is a way of managing the breathlessness. Oxygen alone will make the carbon dioxide levels go up, so it will worsen the whole condition. So we don't usually provide that.